Hello everyone, and welcome to this webinar. Thanks for joining us. My name's Dr. Emma Woodmansey, and I'm an Honorary Senior Lecturer here at Cardiff University. I'm also a scientist, a microbiologist by background, with 20 years plus experience in wound care. Today I'm going to be talking through the evidence supporting supplementary oxygen and how that can benefit chronic non-healing wounds. So thinking about oxygen and its use in wound healing, normal wounds require a lot of oxygen in many of the processes throughout that wound healing. Just for example here, some figures. A patient with a wound has an increased need for oxygen of over 20% compared to normal tissues, and that rises to 50% if that wound becomes infected, because the body needs to use oxygen for the immune system and for the processes need to fight that infection. So critical in terms of the wound healing processes, but also critical in terms of the demand for oxygen, and the demand for oxygen will go down rapidly when a patient has a wound. You can see that here. This is a schematic showing wound healing. Obviously you can see the phases of hemostasis, inflammation, proliferation and remodeling, and you can see the cells involved and the increase in cells as you go through those different processes. As you can see, the oxygen, which is the oxygen availability, which is the blue dotted line, starts off high in the initial phase but decreases rapidly as the cells involved in that wound healing process rapidly use the oxygen that's available within that tissue. So oxygen demand is huge across all phases of wound healing. However, as you all know, oxygen supply to a wound, particularly when a patient has various comorbidities, is very difficult. And so there might be a need for oxygen to those wounds. So just looking at those processes in a little bit more detail, we covered this in quite a lot of detail in the Year 1 module, the role of oxygen in wound healing, and that recording of that presentation should be on your SharePoint. So if you wanted to look at that and kind of revise on these things and have a look through in terms of the detail about how oxygen is used in the normal wound healing process, I'd definitely recommend going and have a look back at that. However, just to give you a summation before we dive into the supplementary oxygen, oxygen is important in the immune response, basically the ability of the body, the host, to fight infection by using oxygen to produce reactive oxygen species that starts a cascade of enzymatic processes that leads to the production of hypochlorous acid that kills basically bacteria that have been engulfed by immune cells. We know that oxygen can increase bacterial metabolism and biofilm metabolism, which might also increase the efficacy of antibiotics, and we'll touch on that later in a couple of slides with some research that's been ongoing. Oxygen is important for the production of energy, or ATP, and every cell in our body needs energy. So without oxygen, cells can't function properly, and from a wound perspective, that means that wound cells won't migrate, proliferate, cascades won't happen, and wound healing won't happen. So oxygen is critical from that perspective also. As I mentioned, oxygen presence or lack of oxygen in the case of things like angiogenesis can lead to a variety of different cell signaling cascades, which leads to cell migrations to an area, and also then stimulates revascularization in the case of angiogenesis, or reepithelialization and migration of keratinocytes and epithelial cells. In addition, oxygen is really important for the production of collagen, and not only the production in the early stages of collagen formation, but also maturation and remodeling of that collagen, leading to enhanced tissue strength and durability in a wound. So really critical, as you've seen, across all of those stages of wound healing. But we also know that the partial pressure or the levels of oxygen varies in different wounds, particularly in chronic wounds. The oxygen tensions tend to be much, much lower, and that's for a variety of reasons. In normal tissue, the partial pressure of oxygen is around 100 millimeters of mercury. And in a centre of a chronic wound, that can be something around 10 millimeters of mercury, and in some cases 0, depending on the level of ischemia within that wound. So there's not one kind of set level of oxygen, obviously, across the wound, and it varies depending on the patient, depending on the location of the wound, and obviously the patient factors, which I'll touch on in the next slide. It can also vary depending on the wound depth and also the levels of tissue necrosis, for example, in that wound, which can restrict blood flow to the area as well. So it's important to understand how we can measure oxygen levels in a wound. And I'll only touch on this very slightly, and there's lots of data out there which we can guide you to if you want to look at this in more detail. But some of the ways that we can measure oxygenation in wounds, for example, are things like transcutaneous oxygen measurement, and that measures the partial pressure of oxygen tension within the tissue. That's done using a heated electrode. And another way we can look at oxygen levels within a wound is using near-infrared spectroscopy, or NIRS, which you can see here in the picture. This is a handheld device. There's no contact to the skin, so it's quite quick, quite easy to use. And it uses the spectral release from hemoglobin. So hemoglobin that's been oxygenated versus hemoglobin that's deoxygenated produces a different signal, and you can see that through spectral imaging. And looking at the wound on the top here, if you use NIRS, you can see the levels of oxygenation in the hemoglobin within that wound in the map that you see at the bottom there. And so the centre of this wound is 58% tissue saturation with oxygen. So really useful measure, and useful to see that in relation to the different areas of the wound as well. And we'll touch on some evidence that's used that to track wound healing in the next few slides. So why is a wound hypoxic? There are many reasons, and these range from patient factors, wound environment factors, and also the cellular activity that I've touched on already that requires oxygen. So thinking about the patient initially, obviously there's many reasons why patients, particularly with many comorbidities, might have reduced vascular supply to a wound. They may have vascular disease, they may have other comorbidities that affect blood vessels such as diabetes, there may be edema in the limb due to that, the issues with vascular or venous return, and also they may have other coincidental conditions such as an infection, or they may have pain or swelling in the area, anxiety, or they might have hypothermia, which again can affect the blood flow to the area. In addition, other conditions that can affect the amount of oxygen within the tissues, such as COPD, so respiratory illnesses or respiratory conditions, can then lead to a reduction in the oxygenation of the blood, which leads to a reduction in oxygenation of the tissues, particularly in the periphery. So again, lower limbs, etc., which causes multiple problems for these patients. And you know them, you deal with them on a daily basis in terms of multiple comorbidities that add to the problems of wound healing. From a wound environment perspective, obviously the trauma that caused the wound can lead to damage to the microvasculature and capillaries, which again reduce the blood flow to the area, therefore limited oxygen gets to that area in the blood. The contraction of vessels because of the trauma can again limit the oxygen to that tissue. We've talked about edema in a limb, and obviously edema locally as well to the wound can restrict blood flow, which means again you're not getting the best oxygen to the area. Similarly with necrotic tissue, and we know that's why one of the reasons why we need to remove any necrotic tissue, as well as supplying bacteria in the wound with a ready food supply. And infection and biofilm can also cause a reduction in the amount of oxygen within that wound environment because of their demand for oxygen as well. And you can see that in the cellular activity box here. They're proliferating, they need lots of oxygen for if they're aerobic bacteria to be able to grow and multiply. So if you have an acute infection, the likelihood is those bacteria will be taking a lot of the oxygen from that wound. As you've seen, the oxygen demand goes up massively when you have an infected wound. As we've touched on already, host cells need a lot of energy to be able to do the things that need to happen for wound healing. So that ATP production needs lots of oxygen in the various stages. And our immune system needs oxygen to be able to signal to migrate immune cells to the area, but also to produce the reactive oxygen species and the degranulation that happens and engulfs and kills bacteria if you have an infection. In addition, the migration, signaling, the cascades that are needed to start off all of those processes for wound healing, they all consume oxygen, and therefore there's less oxygen available to other cells. So multiple ways in which our body uses oxygen, and multiple reasons why the oxygen may be low in people with a chronic wound. And when the oxygen demand falls below, the oxygen supply, falls below the tissue demand, that's called hypoxia. So thinking about these wounds, and obviously there's low levels of oxygen, you can see how variable it is from the mapping, the NIRS mapping that I've just showed you. But what can we do? What can we do about that? Obviously we can revascularize a patient from a kind of systemic perspective, but that's not possible for all patients, and it's not always successful. So can we supplement oxygen into that wound? And the answer is yes. There are multiple ways in which we can supplement oxygen to a chronic wound, and some of those are shown here on the slide. And you can see the first one on the left here is systemic supplementation of oxygen. That's using hyperbaric oxygen therapy. So hyperbaric means high pressure, and basically the patient with a chronic wound is put into a high pressure chamber, and these chambers are similar to those used for diving incidents where people have the bends. They've got oxygen bubbles in their system, and you need to put these people at high pressure to reduce the effects of that. Also used a lot in places like the United States, where this therapy is indicated for treatment of chronic wounds. The patient with the wound is in the chamber, and they have kind of 45-minute periods within that chamber for 5 days a week for, say, maybe 4 weeks. So it's kind of a 4-week level therapy. The patient needs to be at the specialist centre, so there's a lot of kind of travel involved. It's very expensive. And you need a lot of specialist equipment. So it's quite limiting in terms of the amount of people that actually have access to that therapy. However, the oxygen levels that are provided by hyperbaric oxygen is huge. So the partial pressure, as we talked about in a wound, normally is about 100 in a healthy normal tissue. And the levels of oxygen can go up to something like 1800 millimeters of mercury in a hyperbaric chamber. And obviously, it's only when they're in the chamber. So as soon as you're out of the chamber, the levels start to decline again. So there's other ways in which we can supplement oxygen to the wound, and instead of systemic, there's lots of devices that provide topical oxygen locally, i.e. topically. There's intermittent topical oxygen therapy, or ITOT, and this is provided with an oxygen producing unit here, and oxygen travels along a tube to either a boot or a chamber, and the limb where the wound is obviously saturated with oxygen within that boot. Obviously, it's a little bit more flexible than the hyperbaric oxygen, but it still limits the patient in terms of what they can do. They still need to sit for a period of time, I think it's up to an hour a day, to have this treatment. And obviously they need to remove the dressings and the compression that they had on to be able to do that as well. So it's useful in terms of they don't have to travel to a hospital, but it's limiting in terms of the patient kind of activities and getting their life back, which is why things like the sprays, the hemoglobin sprays and the dressings that produce oxygen, as well as devices that are battery powered like the continuous topical oxygen therapy here, are useful because patients can continue their daily activities whilst receiving therapy, and the therapy, particularly with the continuous topical oxygen, is 24 hours a day. So there's no break in therapy because they need to go to work or they need to visit family, etc. And it just fits with daily activities, which is useful. So for that reason, I'm going to talk around this area particularly because this is one that has quite a lot of evidence in support of that for a chronic. So we just touched on hyperbaric oxygen therapy, HBOT and TOT, lovely acronyms. And a lot of people think, oh, well, you know, it might be this or it might be this. But actually, when we're looking at these therapies, they can actually be really complementary. And this is a paper, this algorithm is taken from a paper that we recently published in Podiatry Management around the use of both hyperbaric oxygen and topical oxygen for non-healing DFUs. So here we look at, obviously, if hyperbaric oxygen is indicated, that patient will be receiving hyperbaric oxygen for kind of 45 minutes a day. Can we use topical oxygen in parallel to that in the breaks where they're not receiving hyperbaric oxygen therapy? And then also after they've finished the course of hyperbaric, they may want to continue with topical oxygen therapy as of the add-on to the good standard of care, i.e. offloading, cleaning, removal of necrotic tissue, etc., etc. So it's really important to think about these therapies as complementary. Similarly, that you would look at negative pressure. So you may have a negative pressure with a canister in hospital, and you might then want to step down to a single-use negative pressure, for example, in the community. And this is similar from that perspective, but just obviously supporting provision of oxygen. So we've touched on the different modalities, and these are the topical oxygen modalities now. So cyclical or intermittent topical oxygen, hemoglobin sprays or different kind of oxygen dressing supplies, as well as continual topical oxygen therapy or CTOT. And when we think about the different parameters, obviously evidence is one of the key things. We all want to practice evidence-based wound care. And both cyclical intermittent topical oxygen and continuous topical oxygen have had the highest level of evidence, i.e. meta-analysis supporting its use. However, as I mentioned, the practicalities of some of these therapies mean that it's not always the best therapy for the patient and for the patient returning to their daily activities. So it restricts the patient mobility. The oxygen's not produced continuously, and therefore they're limiting the amount of benefit they can get from that really in the timescales. So topical oxygen therapy really ticks many of those boxes in that you have that therapy ongoing, and therefore really increasing in the level of evidence that people are kind of finding this and seeing how fantastic it is in terms of the intervention and how it can benefit those patients with chronic non-healing wounds. And you can see this is just a graph showing the amount of evidence over the years for published evidence on topical oxygen therapy in wounds. And you can see the kind of exponential increase there in number of publications on topical oxygen therapy as people start to use this therapy more. And that's reflected again in the many meta-analyses that are out there. I think there's 5 listed here, and now I think there was one published just recently as well. Basically, the high-level evidence, the RCT level evidence, has been pooled into a meta-analysis, particularly looking at the effect of topical oxygen therapy on diabetic foot ulcers. And you can see here, I won't go through the details, but many different studies highlighted in terms of the rate of wound healing significantly better compared to controls, the improved wound healing at 12 weeks for DFUs compared to standard of care, the increased chance of wound healing, the increased likelihood of wound healing, and that at the bottom here, that increase is more than 2 times more likely to heal with topical oxygen versus standard care alone. So these are all really high level studies that are pooling data from RCTs. Many of those RCTs are listed here, showing the clinical evidence for topical oxygen in non-healing chronic wounds. So this is DFUs particularly, various RCTs with beneficial effects on healing. So here we've got 145 patients, 44% healing rate in the standard of care plus topical oxygen group compared to only 28% in the standard of care alone at 12 weeks. And interestingly, this study also had a follow-up a year later, and they found that 85% of those patients that had topical oxygen therapy remained healed at 1 year compared to 60% with standard of care alone. And that's critical when we think about things like collagen production. As I mentioned earlier, the durability of the collagen and the strength of that collagen is dependent on oxygen, which can affect, as you can see here, the decrease in likelihood of reoccurrence of that wound because it's more durable, it's stronger. Similar results with Nidorar. This was a different topical oxygen therapy, similar 46% versus 25% in the standard of care. And also down here, 8 weeks treatment with topical oxygen therapy, 90% healing rate within the 8 weeks in the topical oxygen therapy arm versus only 30% in the control arm. So really significant difference in a short period of time for those wounds, and that's obviously why that data is so strong within meta-analysis. What about outside of diabetic foot ulcers? So this is a study on 200 non-healing wounds, so a retrospective study looking at wounds that had topical oxygen treatment. And you can see it has a massive decrease in wound area, so impact on those wounds. Really difficult to heal wounds. You can see here the mean duration of nearly 11 months in many of these wounds. So they've been stagnant for a long period of time, and topical oxygen really changed the trajectory on many of these wounds. The wound area reduction was variable depending on wound type, with arterial ulcers being the lowest responders, interestingly. Whereas venous leg ulcers had the biggest response of 34% in this study. It's also worth noting that when the treatment time was longer than 25 days, you had a 2 times greater reduction in wound area, which again links into what we were talking about in the earlier slides, in that oxygen is needed across all stages of wound healing. So if you only treat with the first 2 weeks of a wound, you're missing the need for oxygen in those later stages of wound healing as well. So it links in together with what we understand to be the mode of action of topical. Interestingly, as well as the benefits to topical oxygen therapy on healing, we've also seen a concurrent reduction in pain in many of the wounds that are painful, particularly venous leg ulcers. And this study highlighted that clinically. Not only did they see a 40% healing rate with topical oxygen, it's really hard to heal painful wounds, they also saw a significant reduction in wound pain after about the first week. So really critical. Obviously, you understand wound pain can have a massive impact on patient quality of life, and it's really debilitating. And obviously, because of wound pain, patients need to take a lot of medication. They try many different pain medications to reduce that pain, and not many of them work. Excuse me. And in this study, because of the reduction in pain because of topical oxygen therapy, 69% of patients stopped taking opioids within that study because of the topical oxygen. So we don't really understand the exact mode of action of why topical oxygen can reduce the pain. Obviously, it has an effect on healing, which in turn will reduce pain, but it's earlier than that, and we think it's to do with reduction of inflammation in that chronic wound. So it's pushing that wound away from that inflammatory state into a more healing state, which will have an effect on the pain within that wound. So I touched on earlier the ways we can measure oxygen within the tissue in a wound, and we talked about NIRS, the near infrared spectroscopy camera, and this study that was published just recently actually highlights the relationship of tissue oxygenation measured by near infrared spectroscopy and wound healing. So you can see the graph here on the left, tissue oxygenation in the continuous line, and then the dotted line represents the surface area of the wound. And you can see as that tissue oxygenation increases, the surface area goes down. So the benefit of that tissue oxygenation is obviously leading partly to the reduction in wound area that we see. And you can see that obviously in the graph, and you can see that in particular in the images that you can see on the right hand side. So this patient, week 0, has 69% saturation in the center of that wound, and obviously the areas to the outside are slightly different oxygenation as well. So again, that variability within the wound. By week 3, that's increasing to 79%, and by week 5, 83%. So you can see the gradual increase in tissue saturation in that wound coinciding with the wound shrinking, the wound area reduction, and obviously that wound went on to heal by week 11. So the impact, albeit these are only 5 cases, showed that all wounds that were supplementary with oxygen, an increase in the levels of tissue oxygen within that, and that coincided with a positive reduction in wound area. From a perspective also, it's useful to see the impact of topical oxygen, and we can obviously control things a little bit better in preclinical models. So this is a rabbit ear model, ischemic ear wound model. It's used a lot to model different ischemic tissues, and you can see here where we use topical oxygen versus a control at both day 5 on the left and then day 8 on the right. There was a significant increase in epithelialization in that model compared to a control in both cases. So very quick, very significant difference in the cellular behavior in this preclinical model. And that was again reflected in this mouse model. You can see here the control wounds on the left panel and the oxygen treated wounds on this right hand panel. By day 10, quite significant difference in the size of those wounds, and complete reepithelialization happened at day 10 in 57% of the wounds that would manage with topical oxygen versus 25% in the control. So again, this is similar to the levels that we're seeing in the clinic as well, which is reassuring. What we also see from this study was when histology was taken of the tissue within those wounds. They found an increased collagen deposition in the wounds that were managed with topical oxygen. And again, this is linked to, as I mentioned earlier, the need for oxygen in all stages of collagen deposition and maturation. And they found that in those wounds treated with topical oxygen, that the fibres appeared to be much more organised with topical oxygen, which is suggesting that remodelling and maturation phase is much more advanced with topical oxygen compared to the control. We also know oxygen can have a massive impact on the microflora of chronic wounds. And this is a kind of snapshot, if you like, of the different types of bacteria, big groupings of bacteria within different populations of chronic wounds. So venous leg ulcers, diabetic ulcers and pressure ulcers. And they all have slight differences in terms of the types of bacteria that you see in them. So for example, the aerobes, which are bacteria that tolerate and love oxygen, are much higher in venous leg ulcers, which are obviously shallower, and there's hardly any anaerobes in venous leg ulcers. So these are the bacteria that can't tolerate oxygen. So if they have oxygen there, they die, basically. However, the amount of these anaerobes increases massively in diabetic wounds, but even more so in pressure ulcers. And obviously that might be due to the increased depth, which means that there's less chance of oxygen from the environment affecting those bacteria and killing them. So obviously there's a difference in the amount of different types of bacteria within these different chronic wounds. But can we change that? Can we modify that with topical oxygen? So can we get rid, for example, of some of those anaerobes by applying topical oxygen to a wound? And the answer is yes. So this study looked at 6 chronic non-healing wounds. Within that, they had 8 weeks worth of topical oxygen therapy, continuous topical oxygen therapy. 5 of those wounds went on to heal, and 1 of them didn't heal. In that wound that didn't heal, there was a residual level of anaerobic bacteria that persisted. The other wounds had anaerobic bacteria at the beginning, but the treatment of topical oxygen therapy reduced those numbers of anaerobes, and they went on to heal. So you can see, and this graph highlights that in terms of the anaerobes. The anaerobes go down significantly, particularly in the first few weeks of treatment, and that had a massive impact on allowing those wounds to progress to healing. So yes, we can modulate the microflora using topical oxygen. Another way we can maybe moderate the microflora is their behaviour. So biofilms, as you all probably know, and I'm sure you've touched on it throughout your course, biofilms are really tricky in non-healing wounds. They can cause delay to wound healing because of the inflammation and the damage to tissue that they can cause. And they're also really difficult to get rid of because they can evade the immune response. And also treatment of biofilms is tricky because they are tolerant to antibiotics and antimicrobials because of the way that they protect themselves within their matrix. So just as an example, silver dressings, even the highest level of silver dressing that's out there on the market at the moment would need to be 100 times more concentrated to be able to kill biofilm bacteria. So they require a lot of antimicrobials to be able to kill them. And that's because of their structure, because of their matrix. They're protected like an umbrella from these antimicrobials, but also because of the low levels of oxygen within a biofilm. Oxygen levels particularly are decrease with depth into the biofilm. So this diagram here shows oxygen levels on the outside being reasonably high, but on the inside of a biofilm, the center of a biofilm, the oxygen level is particularly low. And for that reason, the bacteria that are within that centerpiece of the biofilm they grow extremely slowly. They're almost hibernating. Their metabolism is really, really slow. And for that reason, they don't uptake antimicrobials. So that's one of the reasons why antimicrobials fail in biofilms. Also, some antibiotics also require, like gentamicin, require oxygen to be available to have their effect on bacterial cells. So there's multiple reasons why oxygen is needed for killing within bacterial cells. So this reduced metabolic activity might be something that we can in terms of waking up those biofilm bacteria, and that's something that Professor Thomas Bjarnholt and his team in Denmark have been looking at in relation to cystic fibrosis patients. They've shown that if they add supplemental oxygen to bacteria that are in a biofilm, they can wake them up. Instead of them having really low metabolism, their metabolism increases, and therefore they're more likely to uptake antibiotics and antimicrobials, therefore more likely to be killed. So they're more susceptible to those antimicrobials. So that's been shown in vitro. Can we maybe think about that from a chronic wound perspective? So these chronic wounds where we know there's a biofilm, we know we have to debride, we know we have to disrupt that biofilm, but can we wake these bacteria up and make them more susceptible to antimicrobials as well? And the answer is yes. So we've been from a genetic perspective, and this is a publication that's recently been released last year in Journal of Wound Care, where we looked at growing a biofilm on some pig tissue and then applying topical oxygen to that tissue, and then looking at the ways that the bacterial genes, the expression of those bacterial genes changed when we put the oxygen on it. And what we found was that oxygen led to upregulation of genes that were linked to metabolism or increased metabolism, and the genes that were linked to biofilm formation actually reduced. So the need to form a biofilm was less because the bacteria were thinking, yay, we've got lots of oxygen, we can now grow quickly and we can afford to grow quickly. And this is a really important finding because, again, it helps us to understand the behaviour of these bacteria and how we can, with topical oxygen, maybe change that behaviour, making them more susceptible to antimicrobials. So when we're thinking about antimicrobial stewardship, antimicrobials at certain level will be more effective if we add oxygen onto a biofilm, which is really important. So thinking about this practically, topical oxygen, you've seen obviously the evidence supporting it, but how can we use it in practice? There was a recent document in 2023, international consensus, that highlights the key areas of topical oxygen therapy and the evidence behind it. But they also looked at a basic algorithm in terms of when we should be thinking about using topical oxygen therapy in addition to our standard of care. And this is usually, if a wound is not healing and it's not reduced in more than 50% in size by 4 weeks, we should be thinking about adding topical oxygen therapy to our standard of care as an adjunctive therapy. And that's in the best statement practice from Wounds UK in 2022, where they were looking at active treatment of chronic non-healing wounds in the community. Similarly, if a patient was not on that healing trajectory after 2 to 4 weeks, the consensus here was that they should be looking at adjunctive therapies such as topical oxygen therapy to really progress that wound and kickstart that wound into the healing process. Again, topical oxygen therapy, because of the increasing level of evidence that we're seeing, the high quality level 1 evidence, we're seeing it included in a lot of guidance documents as well, and moist practical implementation of local treatment concepts. This is similar to the TIME acronym, but also, as well as tissue infection, moisture balance and EDGE, they also look at oxygen balance, which is interesting. And here they have kind of summarised the evidence for topical oxygen and also highlight that it's an increasingly well-documented scientific field that it can really impact healing, particularly in those really difficult to heal wounds, and that can be the case across all chronic wounds. So really useful to see that being flagged in kind of practical care documents. Similarly, Health Technology Wales produced a technology guidance document back in 2022, and the guidance here concluded that topical oxygen therapy improved wound area and time to healing compared to standard of care alone, and that the evidence therefore supports the routine adoption of topical oxygen therapy in addition to standard of care for the treatment of patients with chronic non-healing wounds and complex DFUs. The guidance then went on to say that actually the evidence was that strong for topical oxygen therapy that people should be justifying why they're not using it, not why they're using it, which is interesting. You know, in those patients where nothing else is working after 4 weeks, we should really be thinking about topical oxygen and how we can readdress that balance. The level of evidence has been also reflected in the recent 2023 update to the International Working Group for the Diabetic Foot Treatment Guidelines. Within that, again, they highlighted how the evidence has substantially expanded in the last 4 years for topical oxygen therapy, and that clinicians should consider the use of topical oxygen as an adjunctive therapy to standard care for wound healing in patients where standard care alone has failed and where resources obviously are available to support the intervention. The Wound Healing Society in the US have included topical oxygen therapy in their recent guidance in 2023, highlighting the level 1 evidence that we've talked about in this presentation. It's also essential, that highlighted the essential role of oxygen in wound healing, and that topical oxygen has been shown to increase the incidence of healing and decrease the time to heal, as you've seen from those meta-analyses that we discussed earlier. And that's reflected again in the American Diabetes Association Standards of Care document, both in 2023 and 2024, who listed this as having grade A evidence, which is clear evidence from well-conducted generalizable RCTs that are adequately powered. And their recommendation is grade A for an adjunctive treatment for chronic DFUs based on its strength of evidence. So really useful to see that evidence being reflected in the guidance documents, but obviously it's important to then see how that's incorporated into general practice. So just to summarise, obviously we've seen how important oxygen is across multiple processes in wound healing, and how in many cases that oxygen demand outweighs the oxygen supply, particularly due to many multiple comorbidities in the patients that we see with chronic wounds. The chronic wounds have variable levels of oxygen, but we can supplement that with supplemental oxygen either through hyperbaric oxygen therapy or through topical oxygen therapy, as we've talked about today. And the levels of evidence, particularly for topical oxygen therapy and the benefits to that patient, have been reflected in multiple international guidance documents that are incorporating the high-level meta-analysis data into their guidance, practical guidance for use of topical oxygen as an adjunctive therapy in those wounds where healing's not occurred within 4 weeks. And it's also being used more widely as well to reduce wound pain in those particularly painful chronic wounds. So hopefully that's given you a bit of an insight into how we can supplement oxygen into these chronic non-healing wounds, and look forward to speaking to you in the Q&A if you have any questions. Thanks very much.